So I am going to, before we get into the agenda, just go around the room and do introductions, because I know we have a lot of folks from community here, which is awesome. So thanks for extending the invite. I love a packed room full of Oregon folks, so thank you. So I'll start and then we'll just go around the room and we'll kind of then move into the agenda. So I'm Sarah Foster. I'm the Healthcare Industry Consortium strategist for today. Any other questions can be at a different time. Go on.
I'm Eric Jepson. I'm the principal of Gentle Strategies, and we're the firm that's been conducting the focus groups.
Great. Dave Kohler, Dean of Instruction for Health and Public Services here at Rogue Community College.
Lisa Parks, Dean of Workforce Development here at Rogue Community College.
Rob Winningham, professor at Western Oregon University.
Christina Freed-Peters, Tribal Community Health Provider Program Director for the Northwest Portland Area Indian Health.
I am Brian Fix. I work as the CHRO at Sky Lakes.
And I'm Becky Holtberg. I'm the president and CEO of the Hospital Association of Oregon.
And I'm Adrian Bennings, the president of Portland Community College.
Good morning, everyone. Beautiful weather, by the way. Beautiful day here. I'm Maria Love, with president of Advanced Chemical Solutions, also with Governor's Office, Racial Justice Council, and also co-chair of the Health Equity Human Services Committee for the Governor's Office. Thank you.
Morning, Jennifer Purcell, Director for Future Ready Oregon at the Higher Education Coordinating Commission.
Hi, everyone. I'm Maggie Foring. I'll be the Healthcare Industry Consortium strategist after today. Not today.
Brent Hill, CEO of Value Immediate Care and also board chair of Rogue Workforce Partnership.
I'm Bautista Sanchez. I am the director for So Healthy, which is the Southern Oregon Health Equity Coalition. I am also on the Governor's Racial Justice Council and serve with Brian on the Health Equity and Health and Human Services Committee.
Hi, I'm Neelam Gupta. I'm the Director of Clinical Supports, Integration and Workforce at the Oregon Health Authority.
Hi, everyone. I'm Stafford. I'm the Executive Director for the Rogue Workforce Partnership. We cover Jackson and Josephine counties at the region's Workforce Investment Board.
Good morning. I'm Michelle Preston. I'm Associate Dean, College of Health, Arts and Sciences at Oregon.
Good morning. I'm Brad Paper. I'm with the Southern Oregon ESD Regional CTE Center together in focusing.
Good morning, everybody. I'm Liz Rain, and I'm over at Oregon Department of Education. I support career and technical education at the high school level, the health sciences programs. I'm going to have staff just go ahead and themselves.
Hey everybody, I'm Simon Spray. I'm the administrative specialist in the trading team and the consortium administrator for all three industry consortia. Also, just a quick note about mics for today. They are sitting right in front of the executive team right there and along this row. So they are particularly susceptible to side chatter. So just
Old snark.
Hi, everybody. I'm Emily. I am the Office Support Specialist for Future Ready Oregon.
Hi, everyone. I'm Stacey Calkins, and I'm a grant admin on the Future Ready team, and I manage the Prosperity 10,000 and Workforce Benefit Navigator grant.
Hi, I'm Shauna Tice, and I'm the industry strategist at work with them.
Hi, I'm Alex Bruno. I'm a research and data analyst for Future Ready Oregon.
Hi, I'm Katrina Machoro. I'm a grant administrator on the Future Ready team, and my portfolio is manufacturing and presenting the Workforce Ready grant.
Hi, everyone. I'm Shali Hudson, and I'm a policy advisor in the Office of Community Colleges and Workforce Development.
Hi, all. I'm Laura Idem. I'm a communications specialist for Future Ready Oregon.
Wonderful. I think everyone has introduced themselves. You want to? So just quick overview, and we're about to probably switch things around to move into a time certain agenda item around public comment, but I'm going to walk through just briefly the kind of 4 strategic priority areas that at our last meeting we decided on, and we're going to focus on 2 of them today, which will be industry engagement and learning from regional work. And I'll give a brief update around our medium-term objectives, or in particular around our nursing demand planning work and behavioral health. And then we'll move into a presentation from Roman around House Bill 3306 and talk a little bit about 2025 planning. Then we'll adjourn and move into a site visit, which I'm gonna attend. So it is optional though, but if you wanna see this beautiful campus, Dave has organized a site visit. So, we already did introductions, so. Great, so move to the next slide. So I'm gonna move to, can someone move to approve our meeting minutes from our June meeting?
I'll move approval.
Second.
Great. Thank you.
For the record, can I confirm that it was Dr. Adrian Benning that motion, and was it Becky that seconded?
Oh, correct.
Thank you.
Perfect. Thank you, Emily. Do we have any public comments today? Thank you. Yeah. Okay, now that we're through administrative details on public meetings, I do want to, and I don't know that you can see this, but I wanted to remind us, I think it's important to kind of ground ourselves in our priorities every meeting. And so wanted to remind the group where we landed at our last meeting. And as you recall, we teed up a conversation around our process, and we finalized our funding recommendations for the current application that's open or closed, but in decision making for the remaining workforce ready grant program. So moving into our medium-term objectives, we have 4 objectives. One is around nursing demand planning and launching a nursing demand planning work group. I'll give an update on this work later on in the agenda. The second is around behavioral health workforce. I'll also give an update on that work later on. And then the last 2 are around intentional employer engagement. So conducting employer focus groups and determining ongoing employer engagement and feedback loops moving forward, and then learning from Future Ready Oregon and engaging even more holistically, broadly, in active learning opportunities with both Future Ready Oregon grantees. But today we're going to hear from a lot of regional partners around work happening in community. So this is the focus. The last meeting, we kind of focused on the first 2, nursing demand planning and behavioral health. And the focus of this meeting is going to be really hearing a presentation from our consultant, Eric, who will be providing an overview of the findings of the focus groups that were conducted across the state, employer focus groups. So Eric's going to share the kind of final information and recommendations. A report will be forthcoming. And we're also going to learn from community. So I broaden this, learn from Future Ready Oregon, but learn broadly from community. And you'll hear from a panel of folks, I know some of you are sitting at the table, to really hear some boots on the ground work here in Southern Oregon. Great. So before I transition and introduce our first speaker, does anyone have any questions on our priorities, process, agenda, information? Perfect. Well, then my job here is done. Eric, who's going to give the presentation around our employer focus group. So Eric.
Thanks, Sarah. Again, I'm Eric Jensen. I'm the principal of Jensen Strategies, and our firm was the firm that was retained to do the focus groups for healthcare as well as manufacturing and tech. I want to say it's really nice being back down here in the Rogue Valley. I get a chance in my job to come down here every once in a while. It's just beautiful. But I also want to give a special thank you out at the outset here to Jennifer and Sarah and Ronan. We have been working very closely with them over the last few months. And they've been so tremendously helpful and given us such great guidance as we've gone through this and help. I just wanted to say a special thank you to them. You've got a great team. I've got a lot to share. And we're not going to get through everything today. There is a report that's going to be coming out later that will have more detail. So what you're seeing today are highlights. And happy to answer any questions. I'm going to leave time at the end for you to ask questions. And I may or may not be able to drill down a little bit further depending upon what you're asking. So, but we did receive a lot of information. So, with that, I'm going to move on to the next slide. And just an introduction of us. We are a management consulting firm. We're based in Portland. We specialize in state and local government. 99% of our clients are state and local governments. And within the context of that, we do four different things. We do collaborative decision-making facilitation, which is kind of what this falls under with the focus groups. We also do a lot of organizational development work. We do policy analysis, and we also do executive improvements for local and state governments. So there were two of us that were involved in doing the facilitations. I did primarily the healthcare facilitation. I missed one due to an unexpected case of COVID. And my senior associate, Amelia Wallace, substituted for me on that one. That was one here in Bedford. So if any of you were there, you would have seen her. Moving on. So in terms of the objective of what we were trying to do, we understood that you as a consortium really wanted to hear from employers and get the employer's perspective. And specifically, looking at the issues of workforce planning, recruitment, training, development, retention. Oh, sorry, you can press it again. I forgot this one phased in. So that's what we tried to do. We tried to gather as much of that information as we possibly could. We move on to the next one, Ryan. So we conducted 7 focus groups across the state on the healthcare issue, our healthcare industry focus. And that included 6 different areas because Portland, we did 2 in Portland. We also had in Salem, Oregon Coast, Rogue Valley, Central Oregon, Eastern Oregon. So we spanned a good portion of the state in reaching out with the focus groups. We move on to the next slide. Just to tell you a little bit about the focus groups and who they were exclusively employers, healthcare employers. That was the limitation or the criteria that we use for the participants. There were a number of healthcare sectors that were represented in these focus groups. We had the hospitals, behavioral health, long-term care, clinics, community-based care, and federally qualified health centers. There's a little crossover on some of those. Those were the sectors that we had at the table. We ended up with 41 participants overall. And of those 41 participants, we had 33 employers that were represented. And the reason that number is different is some of the employers brought more than one person to a focus group. We averaged 6 people per focus group. The attendance ranged between 4 and 10 people. Some of the sessions, as I mentioned, had 2 or 3 representatives from a single employer. And we did have 1 consortium member participate as an employer. So I don't think he's here today, but Shankar did participate in the Portland focus group. Moving on. So to get ready for the focus groups, we did a series of what were referred to as 12 pre-assessment interviews. These, and many of you here in the room, I've talked to in preparation in doing those interviews. But we interviewed 12 consortium and industry leaders, in part to get a sense of what are some of the issues that we might anticipate in the focus groups when we come up with, when we conduct them. And secondly, with regard to what you folks wanted as a consortium, what information was going to be important to you? Yeah. And then finally, those of you who participated in these pre-assessment interviews, you remember we did ask you about potential employers that we might invite to the focus groups. We did work with the HEC staff also to help identify people for the focus groups as well. So moving on. The format changed a little bit here. So our understanding is that the consortia did come up with some foundational focus areas that you really wanted us to focus in on with focus groups. They focus groups 3 times. One is with regard to demand planning. The second, skills, education, training needs, as well as equity and inclusion, workforce diversity, and then a sector-specific questions for the sectors that we were going after. I'm going to move along because I really want to get to the findings and make sure I don't short-shrift you folks on that. All of the focus groups were organized the same way. That's a typical agenda that you see there on the left. We would have a welcome. We give an overview about what Future Ready Oregon is. We asked the participants to introduce themselves, and I gave them a discussion overview as to how we were going to conduct the discussions, what to expect. And then we went through 4 different topic areas and for discussion. One being demand planning and recruitment. They could be kind of separated out. We kind of did separate them out, but we lumped them in one. And then training and education, career pathways, and retention. You will notice that diverse workforce or priority populations is not on that list. And the reason that it's not on that list is that it applies to all of the areas of the employee life cycle. And so we delved into the priority populations, diverse workforce issues as part of each of those categories. They did get handouts. They got an agenda. They got the list of this group so that they knew who was on the Healthcare Consortium, and a informational piece about Future Ready Oregon. So just want to share with you some observations here from the focus groups. One of the things I really want to make sure that we communicate is these folks were very appreciative of being out. Very appreciative. We were constantly thanked at the end for coming down or coming to their community. And it meant a lot. They also appreciated the fact that HEC took a regional approach to these conversations. The conversations were robust. We didn't have anybody that was a wallflower. Everybody chimed in. Everybody was participatory in all the focus groups. And they kept the conversation constructive, solution-oriented. They also recognized, I think this is important, they recognize that the state doesn't have the exclusivity, if you will, on solving all the workforce issues. They realize that they have a part in that as well. And one of the things that was really keen to see was that they had, they built a synergy between themselves. And so we got a really good dialogue in these focus groups of employers talking to each other and sharing their experiences. So that was a side benefit from the focus groups. And then finally, they all impressed upon us, they want to be kept in this conversation. They want to be continue to be communicated with, involved where they can be involved. And so that is their hope. Moving on. So let's talk a little bit about the focus group findings. Going to the next one, Ronan. This is just a reiteration of what I said earlier in the Venn diagram, and that is, we talked about all these different topics, but the issue of priority populations, diverse workforce span the entire employee life cycle. Moving on to the next one. Some contextual things with regard to the findings that I think are important to raise. One is the information that you're about to hear is information that came from those 41 people. We weren't adding in any additional commentary. We were just collecting and putting that, summarizing that. So what you see today is a summary. There will be a report. I mentioned that earlier. And the findings, most of the findings, I will say, were actually applied across the state. There were some regional focuses, and those tended to be rural versus urban types of differences. But the findings were pretty consistent. So, and then the last thing I want to point out is and I know I'm preaching to the choir here, but the healthcare industry is recovering from the COVID pandemic right now. And so these folks came in just on the other side of COVID, and they're working with a new context, a new environment. They've got a changing workforce right now that's happening coming out of COVID, and they're trying to recalibrate based on that workforce, and how do they shift to meet those new workforce needs. And they're also dealing with unprecedented workforce supply issues. And so they're trying to figure it out. So keep in mind, they're dealing with a new world. So just make that point. All right, so let's go to the next one. We're going to start with demand planning and some of the findings from that. And I'm going to go to the findings, and then I'm going to move on to opportunities after that. On demand planning, we asked them a question. Okay, so how far out do you plan? You plan 5, 10 years out for your workforce needs. Almost unilaterally, they said 1 year or less. That we don't have the capacity to plan further than that. And I asked them the follow-up question of, well, what did you do before COVID? Was that different? And the surprise for me was, no. They didn't, it was not different for them. So that was an interesting finding. I noted up there that there is one that said 5 years, or a few that said 5 years. These were public agencies that had to, for their accreditation, provide a 5-year plan. Their point to us was, yeah, we have to do it because we're asked to do it, not because it is that helpful for us, given the short-term range. Also, they talked about the long-term challenges that they have in terms of doing long-term planning. First of all, it's where they are right now with COVID. They have been catching up on hiring. They've been catching up on doing recalibrating right now. And so to use kind of a medical term, maybe it's a medical term, triage. It's triage for these folks. And then the changing workforce expectations, and they're trying to shift for those expectations, and that right now is a moving target. And they have an unpredictable workforce supply. And that is problematic. And for those in the public sector, they talked about government funding really being a limitation because they don't know what they're going to get necessarily from year to year on budgets. Moving on to the next one. We asked them about where are you getting the data? Where are you getting the information that you need to be able to do demand planning? broken down essentially into 4 different categories. Most of them were using internal information. They're looking at, okay, who's retiring this year? What vacancies do we have? And doing kind of an internal check. They also looked at community and the state in terms of either doing community assessments, looking at demographics. Medicaid participants lists were important to them because they said that helped to be an indicator of a drive for additional need. Regulatory and public funding availability. They talked about being able to meet the state regulations that they have for staffing. They also talked about the, for example, patient nursing ratios came up a lot. And accreditation requirements that they might have in the public health sector and available funding that they might have. In terms of data sources, some of them, and this varied from focus group to focus group, but some of them use data from the Bureau of Labor Statistics. Some of them use information from the Oregon Healthcare Association, and then others went to some of their regional sources and the workforce groups and so forth. But it was a mishmash and it wasn't consistent across the board between employers. Every employer we talked to had a different combination of these available to them. I would point out though that the larger employers, generally speaking, we're talking about the larger hospitals, have greater resources. And so they have the ability to hire consultants to get additional information. And so there was a little bit of difference between what the smaller employers are doing and the larger employers are doing. Moving on to the next one. In terms of recruitment approaches for existing vacancies, I'm not going to read through all these, but generally speaking, everybody was doing the typical postings, whether you're talking about LinkedIn, Indeed, and that sort of thing. And working their networks, doing some social media. Some of them use, and this again tended to be the larger employers use recruiters to be able to find employees. And temp agencies were brought up. International resources were brought up too that were international healthcare associations that they could turn to. And some of them who were really proactive would get out there and do job fairs and the advertising positions out that way. I'd like to also point out that they, and this was almost, I think it was every focus group, spent time with the high schools. They really spent a lot of time trying to expose high school students to the healthcare industry and the career opportunities and starting programs there that high school students can participate in. And I would say that's one area that almost every employer that we talked to said they were doing in some form or fashion, some more proactive than others, but that was a key place. And then also on the higher education, secondary education level, being able to set up programs with some of the higher education institutions for internships and fellowships and that sort of thing. Next one. So we asked them about, so what are the most difficult positions for you to fill? I think this is going to come as a big surprise to you, nurses. That was top of the list. Behavioral health was second on the list in terms of the behavioral health employers are having a really difficult time filling positions. We'll talk a little bit more about that. Techs, any kind of tech was brought up as being difficult to fill. The rest of the bullets are a little more one-off, weren't brought up as much, but multiple times. So you've got dental hygienists, non-credentialed folks, housekeepers and dietary aides. primary care specialist positions, doulas, and patient navigators are the ones that were brought up. But I would say those top three, those were the big takeaways in terms of the difficult positions to fill. Moving on, talking about education and training, we were asking them, okay, so where are the gaps for you in terms of education and training? And I want to drill down, I'm going to drill down on this one a little more because every single focus group brought this up, that higher education graduates that they're getting are not prepared for the positions or the workforce. And that comes in a couple of different ways. And, you know, with our other clients, you know, we're seeing this experience in other industries as well. So this is not, some of this is not unique in our experience to healthcare. But first of all, just on the technical side, that people are coming in not prepared to do the technical work that they need to do in the workplace. These are often people who have not had the job exposure. These, they talk about, in a few cases, they talked about nurses being afraid to give injections. But probably more so, we heard this a lot from the behavioral health community. And the point that they made is that these folks are coming out of behavioral health training, and some of them are ready to do the Fraser type psychiatric approach of, okay, I'm going to go sit down, I'm going to be able to get my notepad out, I'll talk about your family problem, and you know, let's work through it. What they don't, when they get there, they realize, oh no, I'm dealing with crisis management here. We've got people in serious crisis mode. I don't know how to deal with that. Not what I expected. And so that was a portion of it from a functionality standpoint. But there is another piece of this that I want to bring up, and that is, in general, the people, the graduates that they're getting are not prepared for the social piece of work. They're not prepared for the human interaction that they have to work as a team, to have EQ, to have the communication skills necessary. Some of them said, geez, these folks don't have political acumen. They don't know how to be professional in the workplace. And again, I'm just going to say, we've heard this in other industries, but we also heard this loud and clear from all of the focus groups. Now, all that said, many of the employers are working with higher education institutions on a case-by-case basis in terms of being in these students' job exposures. And so it's not like that isn't happening at all. It is happening. It's happening on a case-by-case basis. Usually it's the employers working with their local higher education institutions to do that for internships and such. Clinical rotations and then they talked about the gaps and the challenges in Oregon healthcare education. And there are those that are, I think, obvious to this group with regard to nursing, with regard to tech. But they also, behavioral health was one that just came up again and again and again and again of there are not the programs in Oregon to train people up in mental health, behavioral health that they can draw from. So nursing is obviously one, but the feeling that they have is that there has to be an acceleration here of supply. And how is that going to happen? They also felt that geography was an issue as well. It was difficult, particularly those that are outside of the urban areas or in the smaller, very smaller urban areas out in Eastern Oregon, down in Coos Bay, that they don't have access. Students don't have access easily to that. They also talked about curriculum and having curriculum that's developed without input from their perception of the employer community. And we'll talk a little bit more about that. So moving on, talking about career pathways. Overall, everybody pretty much in agreement. Geez, there really isn't definition in career pathways in the healthcare industry. That people coming out as students or people who are in mid-level positions in healthcare don't know how they get from point A to point B and how they move through the system. Now, that was not true for all of the employers. Some of the employers took the initiative themselves to create their own career pathways within their own organizations. But generally speaking, that from their perception didn't exist. They also talked about the challenge of growth between credentialed positions and how difficult it is to have a career path where you're going through different credentialed positions, not having to leave your employer to go off to school someplace else. And then the employer may lose a good employee and the person doesn't have a job when they go off for education. And so that credential gap is problematic for employers from their perception. And then career pathways for the priority populations are particularly difficult. Not only are there not clear career paths that are being shared with students in general, and again, this is the employer's perception that I'm sharing. But in addition, for them to be able to make transitions, if they have to leave their employer, they've got to get financing. They've got to be able to make that transition. And for many of the priority populations, and I recognize that priority populations by the definition of the legislation was very broad. But for many of them, there's a low income component to it that makes it difficult for them to make that transition and to leave their community to go move on to the next, get training for the next step. Let's move on to retention. So in terms of retention, we asked them, okay, what are you currently doing to retain employees? And we got a variety of answers on that. They were very quick to say, hey, there's a lot of factors right now that are impacting retention, and that had to do with the workforce changes that we were talking about earlier. Talked about things like, well, candidates want to have flexible hours now. They want to be able to work remote. And can we accommodate that? Is that even reasonable? And people are looking at jobs from the standpoint of workplace satisfaction, from the standpoint of, do I feel valued? Do I feel like I have a purposeful job that I'm doing? Do I have a work environment where I like working with all of my peers, where my employer is flexible to my personal needs? That's a changing factor that applies to retention as they're looking at, okay, so how do we need to shift to be able to do that? With priority populations in particular, though, they did talk about it's really important on the retention side of things that priority populations have people and other employees in the organization that look like them, are like them, or organizations that will accept them. And that's really important. If you're going to try and diversify your workforce. They also talked about affinity groups. Some of the retention approaches, some of them do bonuses. They did talk about hiring bonuses, which they cannot do anymore. But they also talked about bonuses for longevity. But interestingly enough, some of them gave bonuses for referrals. So if you as an employee refer somebody to the organization, you can get a bonus. If they stay a certain amount of time, you get another bonus. And the longer that they stay, the additional bonuses keep coming. We didn't clarify how long, but and then paying for their licenses, their credentials, their certifications, helping them with tuition, particularly those that are having to go off someplace else and get additional training, as well as in one case, they talked about housing, financing, assisting with that, as well as just staying competitive with wages and benefits in general. So those were the retention findings. So before we move on, any quick questions? And I'm going to leave for a lot of questions. So
yeah, I have a question. So are you assuming that employers are not really happy or maybe discontent with the way we educate these workforce members? You mentioned the human connection, and that's really important in the healthcare industry. We feel like we're not connecting with people as human beings, and that's causing further disconnect with helping customers, and it's affecting their workplace and how they deliver healthcare services.
Right.
So are they asking for a new change, how we do education, how we provide training, how we work with students? Are they assuming that it's not working right now the way they want it to work? Based on your observations?
Yes.
Okay.
That would be the short answer with a lot of ifs and qualifications along the way.
Thank you.
Yes, that's true.
I just thought it was interesting under the retention section that a lot of the things that providers are doing are giving things to employees. And there are HR experts in the room next to me, Brian. So tell me if I'm wrong here, but I think the data pretty much shows that people leave because of their relationship with their supervisor. And none of those things deal with that. And so I guess I'm curious about, was there any conversation about culture or management training? Because like one observation I've had is that we have a whole new cadre of managers since the pandemic, because anybody in healthcare who could retire did. And so like, how have we prepared and equipped those managers to lead people? And is that what we should be, that's a harder thing to focus on. So it may be why it didn't make it to the list. Like, how do you do that? But I just was wondering if anybody like talked about that.
Thanks, Becky. I appreciate the question because they did.
Okay.
And that was brought up, and we were having to lump some things and for summary purposes, but when you talk about a workplace where they feel comfortable, where they feel valued, that falls under that. If they're working with a manager who doesn't show them the value or is helping to mentor them or to bring them forward, then that definitely plays into it. And yes, we did hear about that. Thank you. Good question. Yes.
I similarly to that, I sort of was wondering if some of that was generational and cultural, and just how it's really hard if all of your management team doesn't look at all like the next level of people below them, and what that experience is. Sort of to your point, people leave not because they're not getting paid enough, but because their manager, they don't feel, some affinity with their manager. And you sort of talked about affinity groups, but I also hear this a lot in different sectors because we're working to train individuals, is also how when we bring, so I work for American Indian Alaska Native communities, when our students go out to these education institutions to get educated and then they come back to their communities, they've had to sort of code switch into the dominant culture. And then they get back in their own communities and they don't fit anymore because there's so much sort of inherent, like, tribal is bad in that dominant culture, so that they get home and now they can't even identify and serve the population that they came from in the first place. And I can't imagine that would have come up in there, but it's something that we keep in mind when we're thinking about, like, what does training for managers and for others look like? The other question that I had too was, did they find the 5-year planning at all accurate? You had said that they only do it when they have to. And I'm like, well, did they just put down some numbers and then look at it later and go, oh, this is stupid.
Yeah, and, you know, one of the things that we did guarantee, all the participants was anonymity. And so we did get some candid responses, and I think the candid response with regard to that one was, we have to do it. So, you know, we'll do our best, but really it's not a helpful exercise.
That makes sense.
Yeah. Okay. All right, I'm going to move on.
There's a question on that.
Oh, good.
So the feedback about lack of communication skills, is it emerging, is it all of the workers right now? And then question 2, the employers indicate if the pensions throughout the months are affected.
Two very good questions. So with regard to the question, does it only apply to nurses or certain professions? No, it applies across the board. This is a cultural shift that's happening. The second question was, I've already forgotten what it.
Oh, did employers indicate if these retention strategies?
Yes. For the most part, they said were helpful and were effective. Making note that you put out employee satisfaction surveys, I put in parentheses there, and acts on them. If you do a survey and you don't do anything, that doesn't get you anywhere. But yeah, so I should probably move on. I'm kind of watching the time here. I want to make sure we have a little bit more time at the end for additional questions. Because I know Sarah's going to cut me off here. Okay, so let's move on to the next one, run in. That's just going to be a title slide. Just going to talk about a little bit of the takeaways from the findings first, and then we're going to go in the opportunities. So one of the big takeaways that we heard from pretty much every focus group was there are opportunities here for healthcare employers and for higher education institutions to be able to have some operational type conversations. And what I mean by that is when you're looking at curriculum, having a conversation of what curriculum is going to help the employer moving forward and trying to collaborate on that. They also talked about career pathways and trying to get on the same page with the higher education institutions in terms of what those career pathways look like. So there's some consistency, but also to make sure that there is communication that's going out, both from the higher education institutions and from employers. And then the student preparation for the workplace. Trying to get more job exposure is really important in their view. So these focus group members really emphasize this is a conversation that needs to happen in some form or fashion, and it needs to be an ongoing conversation in their view. The second piece, Oregon healthcare education program limitations and gaps contribute to current workforce shortages, particularly nursing techs, behavioral health. We talked about that before, but the one thing that I would add to this is they had a feeling that there were opportunities coming up, and we'll talk about this in just a second, to be able to help prime the pump, so to speak, on some of these programs to get the capacity to expand. And then accessibility to healthcare education being limited by geography and financial resources. This was also really big. the frustration by a number of the employers who were, say, outside of the Portland area or the Willamette Valley, feeling that they don't have the kind of access, or their employees or students don't have the access that they need to these programs for geographic reasons because it's too far, or financial reasons because they can't afford to do it. And then healthcare employers, that's the employers have a voice in state policy and regulation development. This is a continued voice that they'd like to see continue to happen. They talked a lot about the example of the nursing ratios that came up in almost every focus group. The frustration around that, said, geez, wish somebody had asked us about that. So those were four of the takeaways. On the fifth takeaway on the next slide, more to the priority populations. And with the priority populations, they noticed or they said that they face a greater workforce challenges to a greater workforce diversity. And one is the higher education. They can only get what's coming out of the higher education system. The higher education system is not bringing in the priority populations. That limits their choices. They also mentioned that many in the priority population communities don't have the experience of going through job seeking, don't have the experience of how do you apply for financial assistance. And that there really needed to be some type of way of being able to help give those folks the additional training or coaching that they need. And the lack of career path development, we talked about that earlier. Employers in areas with less diverse populations may be a deterrent. This was a very frank conversation in some of the communities that we were in outside of the Portland and the Willamette Valley area. Some of them they were quite frank in saying, our communities are not necessarily that accepting of some of these priority populations. And if you're talking about priority populations that are race based or LGBTQ, that the communities may not be as accepting, and that is a deterrent for candidates coming in. Not that the organization doesn't want them, they do. But how do they do that when the community is not being as accepting? And then the lack of early job exposure is another piece that's related to the priority populations as well. I'm going to move on for the sake of time. And then, so the big opportunity here from focus groups that we spoke with or got input from is they see an opportunity to foster and support these opportunities with higher education, with the dialogue on the operational end of and linking education and employer needs. Whether it's curriculum or associated programs like career pathways or anything else that supports student success in making the transition from higher education into work. Next slide. Okay. They also, when it came to demand planning, we talked about the data and that everybody's using different data points and some have more access than others to data. They said, boy, it would be really nice if there was a central place where we could get data on everything from demographics to employer retention statistics. We had more than one focus group talk about, geez, we'd like to know if our retention is worse or better than others. That would be really helpful to know. Medicaid participants, physician vacancy statistics, wages, how do they compare, cost of care. But just having that central hub that will help all employers and not just those that might be large enough to be able to gather that on their own. Next slide. So recruitment. We talked a lot about reciprocity, the lack of reciprocity agreements and how difficult it is to hire people from out of state, and that having reciprocity agreements for a similar program. Maybe it's not a reciprocity program, but it's a different kind, but achieves the same thing where you can have a state by state transition that's a lot easier. And to that point, to be able to streamline the process for credentialed candidates that are hired by Oregon employers if they're coming from another state. They're finding they hire somebody from another state and then they have to wait for the credentialing to be approved and to go through. And there was frustration talked about with that. So they said that can be streamlined. That would be great. Collaboration between healthcare employers to share candidate pools. This was an interesting one, and there is a real example that is here in the Rogue Valley. That the ability to bring candidates into a pool that multiple employers can be able to draw from. Our understanding is that some of the healthcare providers here in the Rogue Valley have already started doing that and pooling candidates. So they're drawing from the same pool, particularly for like specialists. That's beginning to be done and recommended. Creating new rules to build the workforce that don't require licensure. Another way to get people into healthcare, being able to have those kinds of jobs. And the one example that we were given was called patient tech. And that was kind of a pre-CNA position where they don't have to have the licensure, but they can get on the job experience in working. And then assisting employers' ability to recruit out of candidates. This one, there's going to be a few things in here that's kind of, I would think, out of the state's control, if you will. But they do express some frustration that it's now a lot more difficult to bring people from out of the country, and probably more of a federal issue than otherwise. So, and then moving on to the next one, Ronan, in terms of opportunities for education and healthcare, we talked about making that connection between the employers and the higher education institutions. Those that were in the rural communities said, we want to make sure we're at the table. We want to make sure we have a voice because we have special challenges in our communities. So as you're talking about healthcare workforce issues, we want to make sure our voice is there. This is not to say that it hasn't been. It's just saying, they're saying this is important. Establishing a state level position charged with coordinating dialogue between healthcare employers and Oregon educational system. You know, we talked about having this operational dialogue between the higher education institutions and the employers, but then at the same time, you're going, yeah, but we don't have time to do that as an employer. We're swamped. And they said, boy, it would be really cool if there was a state position that really, that was their job, to champion that and to move that forward. So they offered that up as a suggestion. Strengthening the mental health or behavioral health professional education systems, big. And behavioral health folks were all over that. And then reducing some of the barriers and red tape. You know, we talked a little bit about some of the financing available for those who can't really afford it. And we brought up the National Health Service Corps, or OHA, SRSA, and they say, Yeah, it's hard for a lot of people to qualify and it's difficult and it's complicated, especially for those who might not be familiar with going through those types of processes. And so they said, if there's a way to make that easier, that would be great. And there's a second sense here, really, that is something that could be a second point or another point. And that is they talked about the nurse, particularly the nursing shortage. And they said a large part of this issue has to do with the instructors. The instructors are not getting paid well and they can make a lot more money. And so these higher education institutions, from their perception, are not able to either maintain or attract instructors into the program, which hits capacity as well. And they said if there's a way to be able to help fund those instructors to help boost that capacity, that would be great. All right, next, almost there. Am I getting the hook, Sarah? Okay.
Yeah.
Very quick. Allowing healthcare employer and staff to teach in the higher education program, that'd be great if we can have some of our practitioners also do some teaching. They talked about creating more job exposure. We've talked a lot about that, enabling healthcare employers to establish credentialing and other training programs on site. So part of the geography challenge, being able to do more training there on site if they were allowed to do that, providing childcare for their employees, being able to establish a healthcare training programs in areas with significant priority populations, bringing healthcare to those communities that perhaps wouldn't be as familiar with healthcare opportunities, and continuing the healthcare career programs in high schools that they've been doing. Moving on to the next one. So on career paths, just defining the career paths, we talked about that. Doing the on-site training, we've talked about that. Finding financial support for living expenses for those. It's not just giving them tuition, it's giving them the ability to live while they're at the school. Bridge positions. This was an interesting one. They talk about bridge positions between credentialing positions. How do you transition somebody from credential position to credential position? If there was something in the area that would help them make that transition, that would be great. I'm going to leave that for the moment. And improving the licensure board processing time on renewals and licenses. And then the last one on retention, just providing education on DEI, both for employees, but also they emphasize for their leadership and cultural competency. Providing on-site childcare, providing employee housing assistance, workplace violence prevention reduction through training. They talk about a lot of crises that they deal with, for example, in the ER, people who are taking drugs in the ER and they don't know quite how to deal with that. Number 5, I would just say that's one of those that there's not much to be said about that. It's an issue and it's something beyond what this group is really dealing with. And then number 6, enhanced education on substance abuse and how that impacts behavior. And that relates back to number 4, so it's kind of repetitive there. All right, that's it, Ronan. We're on to Q&A. It depends on. Sarah.
One, just thank you. I know that this was a really, important exercise for us because I think as I've, been facilitating this group for the last year and a half, it's been, can we boil the ocean? Pick some priorities. I think no surprise that nursing and behavioral health has risen to the top in priorities. But then I think we're asking ourselves like, okay, so what next? how do we drill down like 4 layers deeper into what's like, what do we do with that? What does nursing demand planning in this context actually mean? And what can a statewide table do to remove it, knowing that a lot of this work happens locally? And we're not gonna be the table for everything and for everyone, but how can we support and partner with our regional and community-based organizations to remove barriers for more of this work happening? So part of that exercise was to also know that we didn't have all of the information at our table to be able to make smart and strategic decisions. And so being able to go out and really listen well and have that feedback into our strategy and planning process. So just thank you. And thanks to, I know a lot of our workforce boards, Heather, like really helped with recommending employers to participate. So again, thank you for engaging in this process. Maybe a couple minutes of questions before we move into, because then there's going to be a really rich panel discussion around, okay, what's going on in particular in Southern Oregon. I'm hearing from specific employers and higher ed institutions. So, but we have a couple questions.
Yeah, question and comment. One of the things, and for context, I've been in the state of Oregon a little over 2 years. And so what I've seen in this report, the findings or highlights are no surprise. And what I have observed and experienced is that we have these opportunities and we gather all of this rich feedback, and then it goes where? And I see, and I wonder if there's an opportunity to reconcile the feedback from what you receive from the employers, because higher education is a key conduit, key connector. You've got 2-year, 4-year, you've got the K through 12 pipeline, all of that. I wonder if there's some sort of way to have these similar types of discussions with higher education institutions. So for example, I have quarterly convenings with all 17 community colleges. That space is already created. And so, and then reconciling, so we're not creating additional space, everyone's time is precious. And then the 4 years, I mean, they have their convenings as well. And so I think from our level, perhaps there could be some recommendations that come out of this to have some broader convenings that then draw intersections between what you've heard from employers, but also now what you're hearing from 2-year, 4-year, and even K through 12, because there's the early career exposure, and we partner with K-12, especially on CTE and all of that. So anyway, I just wanted to put that out there. I think that this could be a stepping stone to a larger ecosystem of collaboration, because we have all the pieces, but I won't say failing, but I would say failing, or we're missing opportunities to make deeper connections from our level to now the layers across the local and regional areas. Just my thoughts.
Yeah, I think that's an excellent point. And I would love to see how we can help facilitate that or bridge that gap. And also,
I'd be happy to help too.
There's a lot of richness and depth here. So thank you for your work.
Yeah.
I think we need to figure out how to spend some more time wrestling with these things, because this was a great overview, but I could probably spend another 2 hours like asking you questions.
I had Eric on the agenda for like 15 minutes, knowing that we would have like so many questions and conversations left unfinished.
Just a quick question. So Eric, so the people that you were part of the focus group, what were their positions or status or demographics in terms of who are these people?
We had a pretty good spread, but I would say most of the people were either in a COO position or in HR, or more specifically talent acquisition. Those were generally the positions that we had there.
Was it diverse, female, male, different ethnicities, or what was?
We had a real gender diverse set of folks in all the focus groups I recall. Yeah, very well represented from that standpoint.
I'll be quick, I promise. I also echo Dr. Benning's assessment. There weren't any real surprises, at least for me, just in terms of kind of what on the other side in working with communities that struggle to gain access to care or access to higher education. So there were no real surprises there, but the question that I have is around like, there was something you said they wanted to have more voice in state policy and regulations, and immediately, you talked a little bit about it, but also in like scope, it's really, really hard to change the scope of practice for, a different mid-level provider or something. I've worked on piece of legislation around that. The other big challenge, I think, and I don't know if this came out, but when you have healthcare professionals that are teachers and welders that are teachers, or, some other profession, like how do you keep everybody equal, and what does that do to the cost of the healthcare education program? Because we've also been building healthcare education programs, and you just can't pay somebody 15 times what somebody else is making and have a homogeneous workforce. So how do we answer those kinds of questions? Because they're really impacting kind of that downstream of like, how do we actually do these things? There's like no easy answer.
How to make those connections?
How to just do the hard thing.
Yeah. I understood that's what this group's doing. But I mean, first of all, I think the opportunity here is to start shifting a policy direction that enables those conversations to happen. And you've got a number of associations that are around the table here and outside of this group that represent a lot of these employers. And so being able to use those associations may be a first step in being able to move those conversations forward. But at some point, there's got to be that, this, in my opinion, there's got to be that face-to-face. Who was next? I didn't see.
I wanted to also echo, thank you so much for your work. This is really great information. And we also at OHA, we convene a healthcare workforce committee. We hear many of these themes through our work with the Healthcare Workforce Committee, as well as across OHA's different committees. I just wanted to clarify around the comment around OHA's NHSC, the National Health Service Corps. We facilitate that on behalf of the federal government. So those operate under the federal guidelines. We help, to facilitate like loan repayment, certifying sites, but it is older methodology that we're constrained by, and then we have a set of incentives that help fill in some of those gaps, but some of them are designed according to the high cost of education. So we have a lot of loan repayment that we provide, and so those are some systemic issues that we just can't get around. I also wanted to clarify. You mentioned OHA licensure boards. A lot of the licensure boards are independent outside of OHA. They meet together. I think there are 19 boards that meet together through a health regulatory structure. And the Healthcare Workforce Committee, we brought them all to our last meeting and had a really great presentation from them where, they were talking about some of the processing time delays and provided some information. So, would encourage maybe a future presentation for this group as well.
Yeah, well, I want to make sure there's time for the panel. So appreciated the questions and comments, and also want to name like the healthcare system is complex and the healthcare workforce system is complex. And so Eric is, just to respond, on some of your comments, he's reporting directly what our system is said. And so there can be a disconnected information from local communities to the state level. And I think it's important we still keep that out there. Like, this is what they're experiencing, whether it's, it's the state or federal guidelines. And so understand that the HRSA program is managed differently, but that's how people are experiencing it. And I think it's mindful for us is whether I'm in a state agency or with a gut, that people are experiencing the state. And we need to name that, however uncomfortable that is sometimes. So we have a panel discussion. I'm going to invite Becky, who's going to be our moderator, and Maxwell and Dan and Brian up to the front. I'm sorry, I'm going to put you in the front.
As we're transitioning, just really quick, she is gonna come right now, take away this. So if you want to grab something real quick, please do that before lunch comes.
All right, so I want to get to the panelists and don't want you to hear too much from me, but I think what I want to just like seed the conversation a little bit before I ask you to introduce yourselves and kind of explain your role in workforce. And that is that we're looking at like two dynamics here. One is what can we do on a statewide level, which is important, and a lot of policies driven at statewide level, and there's lots of funding at the statewide level. But I also want to recognize that something I've learned as a non-workforce person coming into workforce conversations is the importance of local relationships in creating the systems that make things work. And so so one thing I'd like to just think about through this conversation is how do we use the statewide platform to create the environment that helps you at the local level succeed and create the partnerships that you want to create. So what do we want? We want things that are innovative, things that are replicable. How do we then replicate that success and that are responsive to the community? And so how do we work at both those levels to do that? So without any more introduction from me, what I'd like each of you to do to start out with is just maybe introduce yourself and talk about sort of what brings you to this conversation, what your role is in the workforce space, what you're doing in your respective areas that you want to highlight. So Brian, let's start with you.
Thanks. So I came back to Oregon about 2 years ago. I'm Oregonian by birth. I'm a fifth generation Oregonian. My family I used to work in the high tech industry. Now I work in healthcare. Back in the day, I built Solar World and FBI company. We did a lot of work in college before Dr. Bennett was there for things like growing robotics techs for the solar industry and things like that. And it was that experience that kind of seeded my thinking about what we need to do to create workforces that didn't exist at the time they were made. So fast forward some years later, I had moved to the Spokane Coeur d'Alene area and found myself looking for work, and my company got bought by some activist investors and ended up in healthcare. And I won't go through that whole story because I never wanted to be in healthcare. I avoided it, and it called me. I found a lot of joy in it because of what we're able to do to impact our communities. And I took on a personal mission to work to end generational poverty in the Spokane area, where we had a lot of that because it has a large rural population, and the jobs weren't as plentiful as they were in a place that had like a high tech sector like Seattle. So what we did with healthcare there was pioneer some pipeline methodologies that started mostly with the community college, then started delving down into the high school level. As I moved back to Oregon and went to Klamath Falls, I was happy to see that the county schools had invested in a couple of CTE teachers, and they actually had a CTE coordinator, a guy by the name of Adam Randall, who's the vice principal. But he's just really super passionate about driving, CTE in a community that really needs it. So we've seen some really cool expansion in that space, which I'm really excited to share with you today. We can talk about things like pipeline programs that start in high schools and involve everything from observation to deployment at the high school level and multiple disciplines in our hospital and clinic systems. To partnerships with KCC for surgical technician selling programs and high school education. The idea is to get these kids on a track that they never get off of. And so we take a lot of burden on ourselves at the healthcare system. We're an independent system. We're not part of Providence. We're not part of Sunday, and we're successful, and we're I won't say profitable, but I will say we're, as a not-for-profit, we tend to try to block her. But we put a lot of community resources back into the community, and some of the exciting pipelines that we're working on now is expanding APP residency to expand primary and specialty care on practitioners and PAs. And starting that as a new program that we can pull students from all over the region. Also, a nurse intern program, we have more nurse interns than the entire rest of the state at Little Sky Lakes. There's a reason for that. And an MA program that starts in the high school and leads our clinics. So those are all new this last year. And looking to do more. We have a doctor of therapy program at OIT now. They share campus and sit next door to us. We're hoping to build a pipeline that starts with PTAs in the high school employment, and earn and learn all the way through your doctorate. So these are unique, and we're trying to push boundaries there because we realize that the help from the state level is not going to quick enough to serve our needs, and so we do it in the community.
Thanks, Brian. Next one.
Good morning, everyone. My name is Max Brooks. I am the education manager at La Clinica. So for those of you who are not from the area, La Clinica is an FQHC that operates right here out of Jackson County. We have 8 community health centers, including an acute care center, women's center, one of the largest standalone dental clinics in the state. And I have been here in this role as education manager for the last 2 years. I worked in higher education for 16 or so years prior to that, and of which actually at SOU with Dan over here. And I also was someone who did not necessarily see myself in healthcare. I was definitely an education kind of lifer until this amazing opportunity came up to work at La Clinica. And I think I resonated very much with La Clinica's mission to serve folks who had not been served as effectively as they could have been over time. I resonated with their desire to do some innovative things, the recognition that doing things the same old way when it came to hiring, recruiting, retention was simply not getting the job done anymore, especially in a COVID and post-COVID world. And so the opportunity to take all this work that I've done with students over time, identifying purpose and passion and how do you make good use of your educational experience? How do you go about education in an intentional way? You plan ahead, developing career paths while also making space for kind of the chaos or unpredictability of a career. All that work that I found so interesting and energizing at SOU and at University of Chicago prior to that felt really valuable in the work that I was going to be able to do here at La Clinica. So my role, it was a brand new one when I started it, part of a pretty brand new team. I'm on a team called the Learning Well that really collects a lot of different seemingly random services and bundles them together in kind of some creative and innovative ways. We have our personal and professional development workshops. We've got the workforce work that I'm doing. We've got our EDI work. We have some wellness programs and grief support. And so all of these things that are we see as part of well-being and healthcare, but don't necessarily fit into the medical or dental or behavioral health spaces that the rest of our organization manages, live together in the Learning Well. So that was a new service area. And then mine was a new position. And so I'm excited to chat about some of what we're doing, but I think the big picture starting point is really that over the last year or two, we've been kind of evaluating needs and looking inward and how are we supporting our current employees, both as a way to recruit people into the organization, but also to hold on to them once we're here and to ensure that they're not just arriving, stagnating, and departing, but actually growing and thriving in the organization. And as we have improved that work, my intention, our intention as an organization is beginning to shift outward. How are we engaging the community and educating folks there so that they are hopefully discovering their place in healthcare, if that's the right spot for them. We would love for them to come work for us. And even if they don't, then we're kind of developing, we're strengthening that pipeline so they can go work for all these other great organizations in the area. So I appreciate the opportunity to be here and anyone.
And Dan.
Good morning, everyone. My name is Dan Denai, and I am the Associate Provost at Southern Oregon University. And I've been in the Rogue Valley for 22 years now. I moved here I'm a psychologist by training, not the kind that actually sadly moves the needle on the discussion today, but it was good preparation for the work that I've done. I think my role here, the evolution of it is that I served as both the chair of that psychology program and also as the dean of our social sciences division, where I'll say a little bit about our programs here in a bit that we offer that I think impact the discussion today. But 3 years ago, I took over as the associate provost, as I mentioned, and that in that position, I oversee all of our academic programs. I think too, it's interesting. I was listening very closely because you all are struggling with some of the same problems that we are at the university. And I think the part that intrigues me is, the SAU is still a very traditional legacy institution. We don't move as quickly as some, including myself, would like often. There's good sides to that as well. But I'm, in the last few years, I've been seeing a shift in the speed with which we move, the urgency with which we approach our practices towards building programs. So I think that's a good thing. And I think the other thing too is, I think it was Christina that mentioned this earlier, the challenge of, I grew up in South Dakota, did graduate work in Tennessee. I see similar problems in those states just because of the very rural nature. As much as we like to think of this as an urban center, and it is, there are many of our students that come from our local reservations and from our rural populations. And there's a real challenge in bringing them into not only the university, but into Ashland, educating them and then sending them back out into their where they came from. That's the challenge. And so that really is what gets me motivated. And we've been doing some really, I think, exciting things in that space to try to, I think, remove the barriers for those students, both at the university, but the pathways that we put them in to streamline that so that it's a seamless transition into that university environment. Sometimes not even coming to campus because we're looking at our remote programs and whatnot. Many of which are in partnership with our local and regional community colleges. So I'm grateful for those collaborations as well. I see some Oregon Tech and some RCC folks here. So great to be here. Thank you.
So I'm gonna go a little off script. We had prepared questions, but I think the conversation's taking us. And I think one of the things that I heard from all of you was around the mission that you have, that you feel for students. And you're all organizations that have a social mission, right? And there's that important social mission, but then there's also this mission of how do I serve these students? How does my organization serve these students? So Brian, you talked about pathways. Max, you talked about not only the people coming in, but how you're caretaking the people in your organization. And Dan, you talked about like how you bring in these roles. So I'd like to explore that a little deeper with each of you. Like how does that lens inform your work? And what are you building and developing to help really, as we talk about priority populations, which we talk about in this context, how you're thinking about that. So I'll start with Max, since we don't, mix it up here a little bit.
Yeah, absolutely. So I think that as I listen to that question and thinking about kind of identity, history, lived experiences, what are the experiences of our patients at La Clinica, in large part because we're drawing we want to be drawing our workforce from that patient population. And so I don't think that our recruiting and retention efforts are going to be effective if they aren't informed by the kind of experiences and identities of the people that we want working for us and serving the patients that are joining us every day at La Clinica. So a couple of different things come to mind. I think one is how do we better integrate with the educational system in the area? So we broaden and deepen the conversations that we are having with the schools in the area. We have had historically, for example, a great partnership with SU for the clinical mental health programs. And we were drawing interns, for example, from there already. We've had some great partnerships with RCC in terms of students coming out of those programs, especially the MA program, for example, is one that we draw a lot of folks from. But that wasn't moving the needle quite as far as we needed to move it. So now we're looking a little further upstream, wanting to connect with high schools, wanting to particularly, just with a little background on the clinic, it started as a community education or a community health center specifically for migrant workers, and was a resource for our Spanish-speaking population in the area. And so wanting to say, how do we better engage those folks as well? So where are we finding those students, for example, in the school system? Where might the school system not be fully supporting them in the ways that the system would like to be supporting them? And can we fill some of those gaps there? Can we provide some experiential learning opportunities? Can we take folks who are working with us and put them in the space to help with education and information and mentorship with students? We're exploring, for example, ways to better utilize monolingual Spanish speakers or folks who are predominantly Spanish speakers, so that they're not missing out on the contributions they can be making, and we bring them in to the organization because they've got such great connections with the community. And then how are we thinking about education, not just educate, are we thinking about education assistance, particularly as they pertain to career pathways in the organization? And I noticed earlier in the remarks that were being made, they kind of identifying what pathways are, filling in some of the gaps of the pathways so that folks don't have to make such a big leap from one position to another. There's some smaller steps for them. And we are really engaging right now and looking at who are the people within our organization? What do our demographics look like? We have great information about our workforce demographics. And if we see, if we set a diversity goal, for example, so we're matching our patient population, where does that diversity live, whoever you're defining that diversity? Is it all in our patient service representatives and MAs, PAs, or are we really seeing that extend all the way to leadership? And if we're not seeing that extend all the way to leadership, what are we doing to pull people along those pathways?
Yeah. Similarly, we're focused on a lot of the same issues. Providing pathways for our students, and I've got a couple of things that I want to mention. We too are having to further upstream, right? We're reaching out to those students at a younger and younger age, middle school, sometimes even a little before that, just to get them familiarized. We call it SOU, Raiders to Bulldogs, Hornets to thank you. Pirates to Raiders. Raiders is our mascot name. And so we're focusing on our middle schools in the region to recruit Latinx students, but really any student who might want to familiarize themselves with higher education, knowing that many of them probably don't have a parent that went to four-year college. So familiarizing them with that concept, letting them know, for me and my training in social psychology, I know this, getting them to know that they do belong in higher education. And whether that be with our two-year partners or at SOU. And that means recruiting them at an earlier age, removing the obstacles for them. Like I said, it's a very traditional system. We have, arcane language like bursar and provost, and trying to get folks familiar with, like, you belong here. And that's been a particular focus of us at SOU. We've also recently brought on a Native Nations liaison, and Kimani Kravitz. We've been working with our statewide tribal partners, and then we recently got funding from the state to expand that. So we're gonna have a pathways. It's specifically focused on educators, pathways for Native educators program. But I think there's room to expand that. It's a half-time position, but I think we can find some money to expand that to a full-time position. But again, finding ways to familiarize those students with the programs that we have. And then on top of that, being more proactive about reaching out to our community partners. We have advisory groups for our healthcare administration program or human service programs. One of very recently, in fact, she's been on board at SOU for 2 weeks. We're calling it our behavioral health initiative. And so we've hired a director to run that program. And one of the first things that we'll be doing is talking about assembling an advisory group with our community partners to hear from those partners what they need. I was jotting notes furiously in the first hour of this, trying to capture. And by the way, I noted that one of the pieces of feedback was allow healthcare employers to teach at marriage. You let me know. We'll take it. We're always looking for that. So those are just a handful of the things that we're focused on in SOU.
Right, Brian, last word on priority populations and supervision services.
Yeah, I think I'll just tell it in a story and try to contain it to just a few of the things that we're doing. So I was at a pretty large meeting hosted by Southern Oregon Educational School District at Oregon Tech some months ago. And there were different students from different high schools around the region that were there talking about their CTE experiences. And there was one group of kids in particular from a small school south of us called Lost River. And they were talking about what they did with FFA. And I was asked to say a few words and we talked a little bit about healthcare. There was a girl that came up to me during the break in the program, and her name's Marita. She said, Mr. Fix, I really want to make sure that I can do one of these things I'm hearing about with these other students who you don't have health occupations or health occupations teachers at our school. And I said, well, we can work on that. There's some barriers there. And so she's Hispanic, she would be first generation, going to college, and she did. And she really wanted to get connected. So as the program was over and I was leaving, she jumped off her bus and stood in front of me and said, I don't want you to forget me. Don't forget me. And so I said, I won't, and so that day I connected her instructor and her directly to my workforce development coordinator that we have in our education department. So we've invested in workforce development program manager to help us drive these programs and have these connections. And so what we're thinking about here is expanding the access to students in our broader region because we're like frontier medicine. When you enter Klamath County, it's 2 hours to my house, and I'm not at the bottom of it, and so you think about, these students growing up in these rural places and what access they really have. And so we have a building that is currently being used as a health education center for the community. And 2/3, it's a larger building, it's a campus almost this size. 2/3 of it is also being used by the behavioral health organization. They have in it classrooms for an alternative school. They have clinic setting. And their lease is coming up. And so I said, well, I want to make this a regional CTE campus. It doesn't have to just be healthcare, but it would sit on the hill next to OIT and the place where all the clinicals are done at Sky Lakes. And it would give students access to labs and teachers and that they don't maybe have to have funded at the local high school. All high schools in the region could participate. And so we think about, as an employer that is a not-for-profit, how do we serve the community and expand access to folks? And that is one, big goal that we have that we could do, but we need the partnership to come the other way. I know there's a lot of energy. Brad and I talked about this for one here in Jackson County, but Klamath Falls is not going to get the same attention or funding. So how do we do that? And we're not willing to take a no answer. We're willing to see what our alternatives is. One other thing I would offer as an example is medical assistants. And medical assistants are often overlooked. They are the lowest paid position in the clinic side of things. But they're really important because they expand access and allow doctors to be productive and advanced practice providers to be productive. And so for every doc you hire, you need to hire 1 or 2 MAs so that they can run the clinic daily and manage the patient population, work out all of that. They're the people you see when you first go, to your doctor. They're the ones that room you, that take your vitals, all that kind of work. They help ensure that, the follow-up is done on your appointment, et cetera. So we had a local program at Climate Community College. It's not developing the number that we need. It's not even close. We need like 35 a year. They developed a couple. So we built our own program internally. We modeled it after a program out of Washington with Washington Association of Community Health. We actually had a cohort that we glommed onto out of Washington because there wasn't one here. They're now approved nationally and accredited for Oregon to deliver MA cohorts in Oregon. But we decided we wanted to do it locally. So we asked the high schools, would you be willing to, and this is really an important piece right here. We asked the high schools, would you be willing in your CTE classes to open in Health Ox a track for MAs? And Climate Community, would you be willing to offset your cohorts so that they're not all coming to us at the same time? Because you guys don't talk together and they all come out at the same time, we can't help you. Like we don't have enough coaches, we can't take them all at that time. We need them to work with industry, so they're coming throughout the year and we're training them throughout the year. So what we're doing is we're working to offset cohorts where we're doing cohorts on our own for our own internal people that started as patient access reps and get the lowest level jobs at us. We're also doing high school cohorts with 2 different high schools. They build their MA classes this fall, first time, completely full. Like they opened them, they have 3 sections. We trained the teachers on the curriculum and bought the curriculum for the schools because they didn't have the funding. And then we're going to start a high school employment opportunity this spring with those students going through those sections where they can be a clinic ambassador. They work for 12 weeks. It's a paid position. They get paid well, like $18 an hour. They can do that instead of working at Starbucks. And they learn the healthcare system and have at the elbow coach. When they're done with that, they can move into a non-licensed position, and then we'll drop them into a cohort next summer where we'll have a fully formed cohort of high schoolers to go through an MA program with 2,000 hours of clinical training that they can test at the end of that for their national certification. So there's a lot in that to unpack, but if you see the needs that it takes to like get the community college, the high schools, the CTE coordinators, the different school districts, the health system. It takes all of us together to do this, to meet the basic needs of what we need for gas to expand access to our community. And we currently have 12,000 patients that are unassigned with no primary care. Think about the burden that places on the state of care and cost of care when we're not catching those preventative things early for those people. So that it's service, to our communities, but it has to be done.
Right, I love that line, don't forget me. I just feel like we should just like keep telling ourselves. I mean, that should be like in front of everything, don't forget me. So I wanna kind of circle back to the question or the comment I started with. How have you been successful in developing the relationships at the regional or local level to make these programs successful, or what do you need to do? And then you can answer one or both. And then what do you need from this at the state level? What barriers exist that need to come down? What resources need to be made available so that those regional partnerships can be successful? So Dion, I think we'll start with you.
That's a good question. I think what's worked are because we work in a fairly small region, it's fairly easy for us to find the right people to get at the table. For the existing programs that we have, our healthcare administration program, our human service program, our mental health counseling program, and we have a few others that I would throw into sort of the healthcare realm. That's our, we have a school behavioral health micro-credential, which has been wildly popular with our education workforce, just because it's a very different model. They can come back and take courses. It's more convenient to them. It's not sort of traditional 1030 to 1230 courses. So that's been, I think, very successful. And then, so we're looking to expand on that model when we bring those people in and we talk about that. There was I think a request from the focus groups about being having a resource hub. And we've talked about whether or not that's the appropriate role for us to play. The challenge for us is having enough person power to be able to do that. So I'm very encouraged by our expansion of that behavioral health initiative. So I think we'll be able to move fairly quickly. one of our limitations, I'm not sure the degree to which the state can help with this, but one of the limitations on the programs that we have are not necessarily the state, but the accrediting bodies. You know, I know firsthand with our counseling program, this is true for, we've been looking at possibility of partnering with the state on a master's of social work, but we're limited by the accrediting bodies in the student to teacher ratios. I heard that come up at a recent HEC meeting, and so I'm curious to know if maybe they can help lean on those accrediting bodies to help relax that. I know the body that looks at the SW program had considered relaxing that ratio so that we can get, it's a matter of increasing the pipeline. We have students that want that degree. We can't offer enough of the degrees because of we actually expanded our counseling program by what seems like a minuscule amount, 6 students this year. We'll add 6 new next year, so a total of 12. But we can probably come close to doubling that number if we could. The trouble is we have to add faculty for every 12 students we let in. So we can do that, but that's the other side of that equation is finding the qualified either social workers or mental health counselor providers that want to teach because they can make more money in private practice. That's the challenge for us. I would love assistance from the HAC or from the state to be able to loosen those guidelines.
I think I'd echo part of what Dan is saying, which is that in this community, whether it's because of its size or just how fantastic the folks are here, it has been relatively easy to have the conversations that I think we need to have, at least as a starting point, right? I know who our allies and partners are in the community. People are more than willing to come to the table. And they come to the table with sincerity and enthusiasm. There are a number of folks here that I've sat around tables with and had these conversations with. You know, met with Brad a couple of times. We were talking about that. You know, Brent down there. You know, RCC. We have these spaces, the road workforce, the healthcare partnership space that allows us to come together quarterly. And there's a lot of value in the conversations. It feels good to sit across the table or a screen from someone who's doing similar work and see them nod along enthusiastically or kind of understand the work you're doing or to be able to kind of empathize with the challenges that you're bumping up against. And so it's great. There's a lot of value there. And it can be inspiring too. So it allows me to come back to my work feeling refreshed and renewed. I think where I see a gap is moving from that initial conversation where we're identifying some goals and identifying some priorities and sharing some stories, moving from there conversation into action, right? So how do we say, great, we've just identified 6 things that we're all struggling with. What now? And oftentimes there is kind of a vague agreement that we're going to move on and do something. There might even be a conversation or two that happens with a subgroup or a working group. But I think creating some more structure, centralization, resources for taking those initial conversations, that initial collaboration and moving it into more active spaces would be useful. And I don't know exactly what the state's role might be in that or the HEC or larger tables. But that's a little bit where I see the gap. And there's also examples of success. So I've not been directly involved with it, but I think about Brent and the SOAP initiative, for example. You might have to have the Southern Oregon as an alliance of physicians and practitioners, or it's helping to bring providers here to Southern Oregon to sell this region as a great landing spot for folks. That's a great example of an idea that existed, and then people got together to work, specifically on that thing and make it happen. So how do we snatch all those other great ideas out of the air and then create designated, dedicated spaces for those things to come to fruition?
Part of our mission at Sky Lakes is to act as a catalyst for change and create vibrant and thriving communities. We chose that because we exist in an underserved area that is economically challenged. And somebody has to jump up and say, not me. And the good news is we have a lot of partners that want to create change. but oftentimes lack the resources. I'll use another example of a different program that we're working on with KCC that's a surge tech program. As far as I'm aware, it's the only surge tech training program in Southern Oregon, but it only has a cohort of 8. And it's constrained because they only have funding for 1 teacher. We gave up someone for that teaching position. They don't make more money at KCC, but they have a mission to do that. And they came from being one of our senior surge techs. That program will only have that 1 cohort over a 2-year period, and won't be able to start a 2nd cohort next year when it really should. You know, just what they can produce each year is about our need. You know, we still have travelers, you know, that are assisting surgeons as surge techs. We still have people retiring, and we're one small piece of the healthcare system in the region. So the help that we could get is fund educators, just fund them. It's so chronically overcredited as a system. Like I have at least 5 staff members that are instructors that I give to the colleges right now in the local area. And that's everything from nursing to this surge tech program, et cetera. Some of them we fund, we just give them because it's not going to happen. You know, some of them we have agreements where they can work part-time for us. So I would encourage us to explore how we fund joint positions, so someone can maintain input in being a practitioner and really be current on their skills and stay fresh and not suffer the burden of taking a 40% pay cut to go be an educator. And I think that joint funding and some appointed positions would really help. That funding needs to be, so we're not begging for grants. And that's how we do it, and we just try to fill out every grant we can and get some money. Either great, and if we don't, we suck it up. And so that, I think that's one thing I would really ask for. And then really understand the need. You know, when I go talk with my local education partners, I show them exactly, I don't hold it back. I show them exactly, here's how many retirements I'm gonna have. Here's how many new docs I'm gonna have with these things I need around them. Here's how many of these I'm gonna need. Here's how many of these I'm gonna need. How well prepared are you to serve that? And they just go like, you can't. So there exists a very large gap between industry, and I experienced this in Providence too. Every time I would work with Washington State or Gonzaga or Eastern Washington down the line, I would bring the data and I would show it, and they would say, well, we can't even serve you, let alone the rest of the community. This doesn't work. This gap is not going away. And we need to partner in a different way so that there's a transparency that comes from industry to show you what you need, but then also to be realistic and say, well, yeah, we have barriers, but we got to work through these barriers, solve this problem in the state, because that's where these underserved populations, these higher costs of giving care continue and will continue to be a story for us unless we solve that. So that's what I would ask.
All right, a lot of challenges, and I want to end on a hopeful note in our 2 minutes that we have remaining on this panel. So I'm going to ask each of you in 1 or 2 sentences just to tell us what's hopeful about this work. Like, what is exciting, what's hopeful, what gets you up in the line to do the work. And I know you just finished, Brian, but I'm going to start with you because it's your turn.
Everything. In past 3 business days, there have been 3 meetings about this in different forums. We had one with OHSU and OIT on Friday, and it has some follow-ups coming out. We had, and the follow-ups hopefully would be making nurse internships easier to do in the state of Oregon. We've already, Little Sky Lakes had one change into that process through the state nursing commission. I think the second meeting was yesterday. I think, Liz, you were there, right?
I was.
Okay, so our workforce development coordinator had the CTE folks out in the area and did a tour and really brought them together in ways they don't get together from individual districts. And then the third is this meeting today. So there's a lot of energy around this. It's the kind of thing that gets me up in the morning, you know, going to battle with unions and going to, you know, solve the relations problems. It's not what I get joy out of. You might think that's the case as an HR guy, but it's not. What gives me joy is working on the future of Oregonians and creating lifelong pathways that give you a living wage and can help your family move forward. So as a person who's from Oregon and goes way back, I knew my great grandparents about that, you know, they were the pioneers that came over in a wagon train. And I've seen a lot of change, and I really have been blessed with that longevity in my family and seeing them. I really want our future to be bright, and these are big challenges that we can go together.
Right, Dan.
Yeah, I would echo a lot of what you just said, Brian. It was very well said. I think that I too have been involved in a number of meetings similar to this, and I'll tell you right now, people understand very clearly what the problem is. They understand the urgency of the problem, and I think I'm starting to see that shift, and I feel like I don't know what the timeline is for considering yourself an Oregonian, but I have a 14-year-old who was born here, so we're pretty close at this point. But we're, if nothing else, we're gritty, and I see that that kind of everybody's starting to pitch in and come up with really creative solutions. Some of which I heard from the focus group. Let's start with those low barrier entry points, the non-licensure positions to get folks' feet wet. And then I love what you're doing, this kind of things, to not only, let's get you into those roles, but then let's train you in so that you have the ability to move in and progress into those careers. So I see that same transition happening in higher education. Like I said, we're a legacy institution. We tend not to move quickly, but I'm seeing us move more quickly than we ever have. When I tamp down your expectations for how quick that is, I still have all of my shared governance and unions and whatnots, but we are moving very quickly. I'll put I forgot to mention one thing. I think this is critical when we talk about removing the barriers for any of our students, and particularly down here in Southern Oregon. It's that there are a ton of people. I know there's debt relief coming in the mix, but what we need is debt-free pathways. That is a barrier for our students, specifically our priority lists. They do not want to go into debt. I think that's true for most of the students. That is a significant barrier. So the more money we get in, debt-free pathways is critical.
Max Osborne.
I think that these are enormous issues that we're wrestling with, and on one hand, that can be discouraging, distracting, depressing. But it also I think it offers the opportunity for a lot of excitement and enthusiasm. The fact that you've had those 3 meetings, the great work that SOU is doing. I think I draw energy from the evidence that folks are coming together to solve these big pictures at the macro level. At the micro level, I think it's the individual folks that we've been able to help. I am 100% sure you can think of students that you've seen move through SOU and have success. The students standing outside saying, "Don't forget about me," and then being able to actually connect with that person afterwards. I think about employees that we have that came out of a high school into a PSR role and have now moved several steps along a career path, who didn't see themselves in healthcare to start with, and now see a future and a career in healthcare. I want to replicate that stuff, and so getting to see those at the micro level is energizing and to be able to bucket.
Sure.
Well, I'll say someone kind of wandered in, Randy, to watch this panel. So I don't know if Randy, you just want to just introduce yourself really quickly.
Real quick, yeah, and I'll save you your 15 minutes later. We're welcoming people back to campus today, so I can talk to a different campus and grab lunch. On behalf of RCC in Southern Oregon, and I know many of you are Southern Oregonians, I want to thank you for having this meeting today. Just from what I heard, those themes are absolutely what we spend most days talking about. We are have really cool things going on at RCC, and much of it is thanks to 2 people we have at the table with you today. Dave and Lisa on our team are leading a lot of our innovative efforts. But I look at labor statistics in our region, and the 5 fastest growing job sectors for the next 5 years in Josephine and Jackson counties are healthcare support and healthcare practitioners. And 2,400, we need healthcare support. We're not going to be able to provide that as a college, no matter how hard we try. Over 600 practitioners. Where we put a lot of focus, and I get excited in hearing some of this, is around where we're doing stackable credentials. So it's our CNAs turning into nurses, and that's changing lifestyles and families in our region. We are welcoming our first cohort of dental hygienists next week. And 11 of our 20 in that cohort went through our dental assisting program. And we need hygienists, and we're changing those lives in those homes. And so many of the people we need to fill the jobs, we're not going to be able to recruit to our region. We're going to have to grow our own. And the way we grow our own in many instances, when I think of healthcare and I think of education, they're working in our buildings already. They just don't have those credentials. So how are we offering programs to meet their needs? And the things you guys have talked about, and where this consortium, I think, can really help, is to identify the gaps in the training. And we wouldn't be able to add a nursing cohort that we just added without support from Asante and Providence, because we can't pay what they're paying on the floor, but they'd rather help us train locally to stay local than to continue to recruit traveling nurses. So I applaud all of you, because I will say partnership's been the name of the game as we've grown tremendously as a college the last couple of years. And our partnerships in healthcare industries are the model for what they can and should look like. We can't do it alone. We have to have our partners. And the work you guys do, I see so many of our partners in the room, and you have a good representative from the colleges and every day at the table with Adrian over there. I just want to say, on behalf of colleges in Southern Oregon, thank you for the work. We're up for the task to work on the training. We need to continue support of you for all the reasons you just identified.
Thank you. And why don't we go to our panelists? We're at lunch. So, actually, it's a lunchtime. We're gonna grab lunches and connect. So we can keep, getting to work. So maybe take about, I'll cut into my time. So take about a 10-minute break. Thank you. So I am just going to give a brief update on our medium-term objectives, in particular around the nursing demand planning and behavioral health work. And it's going to be really brief before we transition to the slide. As you recall, I'm going to ground us in the consortium's objectives through December 2025. We're charged with, and this is in our charter, making strategic policy and funding recommendations to address healthcare workforce gaps and opportunities with the big objective, establish our standing work group structure, and establish success metrics. And a lot of this is going to get passed on to the brilliant Maggie, who is sitting here, who will be your consortium strategist. But next slide. I just wanted to remind folks at our last meeting, and you can't see the header, but for the first year of the consortia's, Becky's gone, but Becky mentioned there was a lot of storming, norming, forming. But this was really the process in which we were doing that. We were learning from Future Ready Oregon grantees. We were learning from community. We were learning from the data. We heard a lot from the employment department and a lot from our colleagues at the HEC at the Longitudinal Data Collaborative, really like what was the demand and how were we matching supply, and how could our groups come together to elevate where we wanted to prioritize. So we then planned with principals, and the first step of this in our short-term objectives was really to use that data and use that learning to apply it to where we wanted to make strategic investments in the current application for Future Ready Oregon. So we chose community, identified needs, understanding that our statewide data can often miss nuance in community. So there was one RFA focus area focused on that, and then there was another focused on the nursing career pathway. And then we're going to act on emerging priorities. That was one of the priorities we acted on, and the opportunity was to inform future rounds of workforce ready grant funding. But then we sat with ourselves, was like, okay, now how do we use what we learned in this immediate objective of advising on workforce ready grant funding and have that feed into a longer term process and longer term priority. So next slide. And I shared this at the beginning of the meeting, but this culminated in these 4 focus areas. Today, we spent our time in the weeds on number 3 and 4. So I'm just going to give a brief update, next slide, on the first 2. Yes, they're bolded. My build slides are on the nursing demand planning. So if you recall at our last meeting, and even the year and a half, it was like, do we focus on cross-occupation barriers, or do we focus on specific occupation families? And I think in a perfect world, if we didn't have the regulatory environment and didn't have all of the occupation families, we might think about cross-occupation opportunities. But I think the reality, and to engage reality, is that the healthcare sector, we don't have a problem with with occupations and licensing. So we really decided, we really do need to get in the weeds and unpack the occupation family. So let's do that in nursing and behavioral health. And as a first step, we talked a lot about nursing demand. Like, okay, we know we need more nurses, but what does that look like in the short, medium, and long term? And at our last meeting, you recall, we talked about this kind of binary out there around the vacancy crisis of like, do we have enough licensed nurses that are just not connected to the right jobs? Or do we have a supply crisis insofar as are we not producing enough nurses to match the demand? And I think so I'll just say, we launched a nursing demand planning work group to acknowledge, and we kicked this work off in the summer, that it's a both and. We have licensed nurses that are not connected to the right jobs, and we have a problem with not producing enough from our education and training system. And so when you think about now setting priorities, which this work group is now charged with, how do we take that both and framing and move to a priority setting process, and in particular, explore some of the best practices that I think were elevated on this panel around employer partnerships, work-based learning opportunities, cross-sector investment opportunities for the nursing occupation family. And so the next step there is we have a wealth, and I'm pointing to Eric for this, sit here anymore, a wealth of information from those focus groups to really get in the weeds around curriculum development, around all of the recruitment and retention opportunities that were named. I think the challenge is, even when I facilitated this kickoff meeting, is there was alignment on the problem, alignment on 10 possible solutions, and I'll ask some of the work group members to comment if I'm missing something. But I think the challenge we have is moving those into action. I think that's the challenge in a lot of these spaces, is what kind of action at the state level can we take on the nursing demand planning priorities that the group is going to elevate. So I know, and I'm not going to put Neelam on the spotlight because I know she was in that meeting and Becky left, but if I did miss anything, please let me know in the nursing space. And I'm sorry, I caught you mid-chew. Intended.
I thought it was a great starting conversation that shows that there is a lot of work ahead.
And I think that for this, it's, I think we got to a good place of like, all right, we have the people to frame this as a both and, rather this set of strategies being in the expanding education and training space, this set of strategies being in the vacancy crisis space. We know that there's a both and framing. Now, can we as a group select, knowing that there are probably 50 priorities that we're really gonna solve our nursing crisis, but can we start with 3?
Yeah, I think another reflection I have is that it would be great to get some worker voice, some nurses to inform this.
Yeah, Maggie and I had that conversation a couple days ago around, and Maggie brings just a wealth of human-centered design perspective to this work. So really eager to have Maggie jump in and facilitate that work group moving forward, because I think we had one nurse in the room, and we acknowledge that that's not, we're not going to develop the right strategies. And so the second priority and update before I move to the rest of the meeting was around behavioral health workforce. And this was in the context of when we know, and Eric mentioned this, is like nursing and behavioral health continue to rise up in both our statewide data, but also what we're hearing from communities is the harder to fill positions. Also hearing from the education and training side of things that there are a lot of barriers to program expansion. And if we're going to diversify and support our priority populations, that we need to be more creative in our funding strategies. And the governor is that behavioral health is a priority and workforce is at the top of the governor's priorities. So our consortium has decided to kind of dedicate some resource to conduct a behavioral health talent assessment. And I'll say the why behind another assessment here is in the nursing data. It's very clear where we need things and how many. And in the behavioral health space, that data is just not as clear. I think that what we're hearing is we need everything, which is fine. But when you need everything and you're planning with finite resources, it's helpful to understand what kinds of occupations and where the largest gaps in our workforce and largest gaps in our education and training system, and what programs currently program inventory exists to in particular serve priority populations and to diversify our behavioral health workforce. So I know that work has kicked off at the HEC, and the preliminary data will help inform both the GRB development process, which is the governor's recommended budget process, which we're currently in the midst of, and then will continue to inform 25-27 biennium investments, understanding that the final product won't be done in time for the GRB development, but we'll get enough information preliminarily to inform that. But we'll continue to inform the legislative session and all of the decisions being made over the next 6 months. So that's my very brief update. I wanted to spend the day on the employer engagement and learning from community. But do you have any questions before we move to the final agenda item? Okay.
We have a lot of work to do.
We have a lot of work to do. We have a lot of work to do. But I hope that now that we have these 4 buckets, it's kind of like, how do we drive action in the 4 buckets and ongoing learning? So hopefully this sets us up for success in the long term. Next slide. So with that, I do want to just kind of pause and say that meanwhile, on the back and I guess behind the scenes, the Future Ready Oregon team has been doing a lot of thinking around House Bill 3306, which Ronan and Jennifer can tee up much better than I. Which was a bill that was passed that basically mandated the Healthcare Industry Consortia look at. Okay, he's getting excited because every time I try to talk about this, I'm like, I don't know, maybe I'm taking in too much information. You can't spit it out on the other end. But we kind of behind the scenes have been doing a lot of work because you all will be informing this work as legislatively mandated. And so wanted to provide just a little bit of opportunity today to brief you on the behind the scenes work, which Ronan will share more.
Yeah, sure. So hi, everyone. Just to reintroduce myself, my name is Ronan Spray. I'm the industry specialist in the Future Ready team. I'm also the public agency administrator for all 3 industry consortia. And today I'm just going to go into sort of a legislative overview and provide some of the background methodology as it relates to satisfying the intent of this legislation. Again, which I will detail in later. This work began in collaboration with Dr. Delplane, who's the former manufacturing consortium strategist who's since left the HEC. And we had reached a point where we kind of felt like we had achieved a first step in understanding sort of the requirements of this legislation and how we might best go about satisfying these requirements. So not to add to your workload, but we are going to add to it. So in this presentation, I'm really just going to cover 4 things. First, I'm going to go over sort of what is the legislative background and some of the key sort of missions identified by Carrie and our work in terms of this legislation. Next, I'm going to go into just a sort of overview of state and federal methodology, as well as satisfying requirements. Third, I'm going to go over how we have used that state and federal methodology to satisfy the requirement. And then at the end, if we have time, provide some patients and considerations and discussion questions for you all. I should say in general, really, it's just a need for great feedback on our process as we sort of understood the legislation and have gone about attempting to satisfy it.
And these slides are in your packet if it's helpful.
And it's going to get very jargony. I do apologize. Try my best. So just a brief, like, sort of overall legislative background in 2022, so my bill 55, also when Oregon was passed, which legislatively established these three instruments. In 2023, in 2023, the healthcare manufacturing Consortia were launched. And then in around, I think, February of that same year, also was passed, the Oregon legislature, which amended the duties of this consortium to all consortium. And then since about December of last year, Michael Delphin and I initial research and implementation. So to get into actually what the legislation is authorized in terms of the duties of this consortium. When this bill was first dropped, it was really focused entirely on reporting and wage requirements for grantees, state earners and programs. But by the time it passed, it really kind of narrowed down. And so ultimately what came out of it was this modification to the industry consortia. So it calls for each of the consortia to establish wage rate standards varied by locality for each occupation within each of the sectors, so manufacturing, healthcare, and technology. Once every 2 years, each consortium shall recalculate the wage rate standards described in the above section using relevant economic and employment data made available by the economic department. And give a statement to the Higher Education Board of Education, summarizing the methodology used to recalculate the wage rate standards, the date in which those standards. So immediately, Carrie and I looked at this and kind of singled out locality and skilled occupation as kind of the two key terms which implementation is sort of hinged on. It's kind of left a lot of gray areas, what counts as a locality, what defines a skilled occupation. So in terms of sort of understanding these terms and how they impact the implementation of the legislation, we met with a couple of folks from the Bureau of Labor and Industries and the Employment Department that provided some guidance on how we could take these terms and understand them as it relates to. So first, skilled occupation, I should clarify both these terms are left undefined, both in House Bill 3306 and in the foundational legislation of Senate Bill 1345. So, skilled occupation, we really narrowed down two possible understandings of this term. The first is a strictly apprenticeship-focused lens. So, an apprentice occupation coming from the Bureau of Labor and Industries. Is customarily learned in a practical way through a structured, systematic program on the job supervised training. It's clearly identified and commonly recognized throughout the industry. It involves manual, mechanical, or technical skills and knowledge that require a minimum of 2,000 hours of job supervised training and requires related instruction to supplement the on-the-job training. There are a number of reasons why this could be applicable. For instance, it has sort of a broad scope. There are around 915 sort of categories of occupations federally that are considered admissible. However, we'll get into some of the nuances of that later. But ultimately, what we've sort of settled on now is a definition that was provided by the Employment Department and formulated specifically in conjunction with the HEC, the Workforce and Talent Development Board, the Workforce Boards, the Department of Education as well. And under this definition, a skilled occupation or a high skill occupation in the Oregon Employment Department categorized as is defined as occupations with a typical educational level needed for entry and post-secondary training or higher, or occupations with an apprenticeship as equitable on-the-job training level. So it sort of encompasses apprenticeships within establishments, or occupations typically needing related work experience or long-term on-the-job training for entry or secondary training or above as competitive. So there are a number of reasons why we sort of are leaning towards this term. First, it's quite a theoretically broad scope of a strictly apprenticeshable skilled occupation. Those opportunities are much more limited in work itself. I believe there are, let's see, around 160 apprenticeship committees in the state, around 45 principal occupations, so categories of occupations that have apprenticeships available in the state. Secondly, although the Bureau of Labor Industries, another reason why we're kind of leaning towards this is because of the overall goals of Future Ready Oregon as a whole, right? They encompass not only apprenticeships, but sort of go beyond that, sort of talking about workforce development opportunities for priority populations in general. It's not really limited to just apprenticeships. And then additionally, there was some significant legislative testimony provided by Representative Foley, who was confident in the bill, indicated that essentially this was meant to fill the gap in the current state and federal law around like workforce training components that are sort of covered by apprenticeships, apprenticeship law, but are sort of missed when it comes to patients that fall outside of that scope. In terms of the second key term, locality, this is not defined again in House Bill 336, Bill 345. However, it has been articulated in previous statutes, mainly referencing the wage rates for principal occupations in public work projects. So under this definition, under this existing definition of this term, the state is broken out into the following regions that you can see on this map there. I will note at this time, we have not mapped any of the wage data that we can so far on the regional breakdown of the state. I really think it's just sort of provide you with a list of options that is good for mapping wage data. There are some alternate geographic breakdowns that we can apply in this case. Local workforce poor regions, economic development districts, and minimum wage regions. I'll provide a quick overview of what that looks like in terms of region breakdown for the state. So local workforce development poor regions, economic development district, and so we're kind of like, I guess we get, this is probably the most specific, and then zooming out a little bit more, and zooming out even more. Ultimately, however, as this bill mandates that this body will rely on relevant economic employment data available through the employment department, we are likely to use OED's existing geographic breakdowns to our initial mapping of the state. That way, you can make the state workforce area and sub-workforce area levels. And just because we're going to go, just because we are leaning towards now, does not mean that in the future we cannot map wage data on the alternate regional geography in the future. So to provide a brief overview of sources that we have used in sort of compiling our understanding of the methodology and satisfying the intents of the legislation. And this is really just to reflect that at this point, this project has been one of a compilation of existing research and synthesizing other sources. So we retained some, again, as I mentioned earlier, initial guidance from Jason Payton, who's an occupational economist at OED, and Stacy Rogers, who is an apprenticeship expert at PCC. The industry sector definitions we received from Bureau of Labor and Statistics and the Employment Department. Locality and apprenticeship definitions come from Foley. Oregon recommend high wage and high skill occupations. The actual list of occupations in each industry sectors that's coming from the Employment Department. And then Oregon wage information, so just information on all occupations across the state. And then federal NAICS code, which is the North American Classification System, SOX, which is the Standard Occupation Classification System, and the OEWS, which is the Occupational Employment and Wage Statistics Program, are all coming from the Federal Bureau of Labor Statistics. So, Brian cut down the chart, but so getting into some of the methodology in terms of like how the state employment department and federal agencies sort of represent insights, implications of the data that they have available themselves. I don't claim to be an expert in wage statistics or wage information, but so this is really just a report of what these agencies are help describing these and quantify. So Oregon Employment Department produces wage estimates. This is all based on the Bureau of Labor Statistics Occupational and Employment Wage Statistics Program. The data that you can find publicly available on the Oregon Employment Department's website all comes from these surveys from the past 5 years. And I can provide a little bit more info about so the Oregon, Occupational Employment and Wage Statistics Program, this is basically a semi-annual survey that takes measures, I think, around like 18,000 businesses or establishments in Oregon for the first 3 years. It's really taking payroll data from those businesses, so like who is getting employed at those businesses, what occupations they're in. And this gets to how the OED defines occupation. So OED's occupation classifications are aligned with the Bureau of Labor Statistics standard occupation classification system. And through this program, occupation is defined as a grouping of a number of similar individuals. This kind of gets at a larger question though, which is how are we essentially defining industries? Like what counts as an industry in the healthcare sector? What counts as an industry in technology? The Bureau of Labor Statistics uses the North American Industry Classification System, essentially to group businesses in different industries. Establishments or businesses are grouped into industries based on their economic activities, similarities in their production processes, and revenue data. In general, the Employment Department and the Bureau of Labor Statistics assign an occupation to a named industry. 25% or more of that occupation employment is concentrated in that industry. So you can have multiple occupations essentially spread out or that are considered to be sort of core occupations in multiple industries. And this is not like this 25% is sort of an arbitrary cutoff that legislators have asked for in the past. It's not like a statistically defined. If that makes sense. Moving on. Here's a list of all of the NAICS designated industries that OED uses in their analysis of the healthcare sector. The number of digits of NAICS codes designates the specificity of the industry. So first two codes sort of generate, first two numbers represent the sort of overall sector, 62 is healthcare. And then as you get further and further down that list, you kind of narrow in. So this is sort of, we could get further in depth on any one of these industries, sort of a broad view of all the sort of major buckets that encompass the healthcare sector, according to the Oregon. I will note, there are around 300 occupations that the Oregon Employment Department considers to be within the healthcare sector. Around 2/3 or 200 of them are classified as high skill occupations.
Ronan, did you say 300 and 200?
Yes.
Okay.
Yeah.
Wow, that's quite
Lots.
a lot.
Yeah. A quick note here on apprenticeships and high skill occupations. There are several occupations that we've already identified so far within the healthcare sector that are not classified as high skill, despite having registered apprenticeship opportunities available in Oregon. This may initially seem to run counter to one of OED's methods of classifying occupation as high skill, which is one of those agencies that has a typical on-the-job training level apprenticeship. In short, while some occupations require an apprenticeship to be certified, others do not. So while an apprenticeship opportunity may be available or encouraged for a specific occupation, if it's not a requirement, the Oregon Employment Department may not classify that occupation as a skill. I think for this sector, there are only 4 occupations that are classified as non-high skilled that do have apprenticeships available, and those are maintenance repair workers, general assemblers and fabricators, stationary engineers and boil operators, and labor, freight, stock, and material workers. So you notice, like right there, those 4 occupations are not necessarily specific to the healthcare sector, but by OE standards, right, that 25% employment cutoff are considered within the center, if that makes sense. And if you have any questions about it, please feel free to jump in. I know I've been moving fast, like sometimes. So moving on to some considerations and limitations to maybe jog your thinking. So will these wage scales for principal occupations be set by wage estimates or by using permanent rates from Bureau of Labor Industries or local industries? There are a number of occupations classified as high skill, which are generic or not specific to a single industry. So going back to that, those occupations that are referenced earlier, like oilers, right? Conversely, there are a number of occupations which are specific to an industry but are not considered high skill. So one of the questions that we need to address is which of these are going to be included in our published wage estimates? Are we going to include both, or are we going to include one or the other? What happens if wage estimates decrease when these rates were established? Will we set a hard floor for wages so that they don't fall beneath a certain level? What wage percentile will be considered entry level? OECD uses wage data for the 10th, 50th, 70th, and 90th percentiles for high skill occupations, but does not have an official standard for which of these constitutes an entry level wage. Similarly, will an entry level wage be essentially the rate standard in terms of the legislative requirements, and will this include a wage progression schedule? Will we attempt to adjust, amend, or update this data in between termination years? So in terms of some bigger questions for you all, what other people, groups, organizations would find this wage data information helpful? What is the landscape of organizational wage data in the state? Where are there gaps? And how can this work, collaborate, or align with existing wage data mechanisms? And really, in terms of, as we're planning to bring sort of a more in-depth dive in terms of occupational wage data itself to you all at our next quarterly meeting, the specific occupations associated with it that we have to see presented. Just because, you know, as I said earlier, there's about 300 occupations in the healthcare sector. That's all we're not taking in. And so they'll sit with for us to be some specific occupations and those students, looking at that huge breadth that is available.
Rhoda, I have a question. How does the cost of living come into play with wage data?
That's a great question. And that's one of the things that I've been asking our wage occupational economists. So in short, it doesn't really, like that would be something that we would have to take on. Sort of publishing these wage rates. I mean, you can, I guess, infer cost of living by sort of the, like over time, you could infer that as wage rates for certain occupations decline or increase in specific regions. But if we really wanted to like dive into like identifying cost of living compared to these wage rates, that would be something that we would have to take on ourselves.
Thank you.
And you're running asking the group if there's, I mean, more, if we want to drill down, like if there are specific occupations, and then maybe I'll just plant the seed around our priorities. The nursing career pathway and behavioral health. And as I think about what we heard in the focus groups of some of the wage gaps and some of the more, like if we're focusing on entry level, occupations, like having a sense of, I think, because it's just me speaking, is having a sense of what the wages are for those occupations and getting a little deeper there, and then to see the, I guess, occupation family continuum, licensed occupations like an RN, or in the behavioral health space in particular. Yep.
Do we also have data for how much it costs for the education programs that are associated with the occupations? I was just thinking it would be interesting to see what's the earning potential versus.
That's another great question. I believe, the employment department does have some of that data, although again, it's not universal across all of the occupations that we consider to be within the sector. So we would certainly be able to pick out like cost of education for, again, I don't really have an idea of how many, but we could certainly do that for some occupations, but we would have to leave that off. So that's a consideration. Let's see.
Someone else had a question, I think, or? Yeah, Christina, I'm sorry.
No, Christina
Okay.
first.
I sort of two questions. I think this morning the panel was talking a lot about kind of the professions around the credentialed professions. And so it would be interesting to understand that. And then in the same vein, it would also be interesting to understand the gap between like the highest paid individuals in this setting and the lowest paid individuals in those settings, right? Just because I think there's some obviousness in that question, but also like how that affects the health of the system overall. If it's really outbased over here and then you're trying to pay people $15 an hour, but you really can't have that person operating unless you have like 8 of these people making $15 an hour who are willing to do that job.
Yeah. That is a good point. And I think that.
Did that make
Some of
sense?
our earlier, it does. I'm just reflecting back and like some of our earlier presentations, like we were looking at home health aides and personal care aides, but I saw a couple others. And so that would be also interesting to kind of look at of the whole kind of care team.
Yeah, to piggyback on that, professions that the credentialing maybe is different. So you take a physician's assistant and then you take an MD, but sometimes that workload ends up getting distributed a lot more equally than one would expect in a busy hospital setting. Yet, what is the wage gap difference there?
I was just gonna add a couple of things, looking back at the focus group findings, sort of the top 3 that Eric said were nursing, behavioral health, and then techs, which I think heard from the panel and we've heard since this group has been convening. And I think informed the priority around community priorities for that most recent round of funding. So I think there's something there. I think the other thing we have to balance is that the directive is around high skilled workforce. And so I think that may limit maybe the more holistic picture, but it's a good conversation. And I don't think we probably have the capacity to like do all 200 or 300. And how do we prioritize what the focus would be? There was some strategy in bringing the focus group findings and introducing this body of work to you simultaneously. Some of it was timing, but some of it was strategic. And I think one of the things that we've been talking about as we think about the next body of work for the consortium is this idea of career mapping, career pathways, credential mapping, credential pathways, and this overlay of wage data. It seems like we have this convergence of opportunity to bring all of that together in a really unique way with the table that we have set here. So planting that seed that I think as we move into 2025, that may be something this group thinks about diving deeper into, and maybe we pick a pathway and explore that as a pilot project.
Yeah, and just on that, there was some talk about the stackable credentials, which is You know, then, and then also the question of individuals who start and stop along their educational journey. And so I think there's rich discussion in that space as well, just sort of piggybacking off what you said.
Yes.
Around pathways.
Avoiding the idea of a ladder, which only has one direction. And how do we think about sort of the on-ramps and off-ramps throughout our career journey?
Well, and the great points, and I hope we're capturing that, because I'm like, what did we say? In talking about overlapping, one of the things too that can be added to that is the demographic shift, because we're seeing that fewer high school graduates are going to college and pursuing a post-secondary education. And when I came to Oregon, one of the terms I heard was birth dearth, and I was like, is that like Darth Vader's son or something? But it was a trend where we're across the state, and I don't know what it looks like nationally, but I think it's also happening in other states. It's not trending from K-12 to the post-secondary sector. Now, why? That's a different level of research, different layers. And then that could have also been compounded by what's happened over the past several years, but we're seeing that and we're, preparing for that. And so that overlap of wages and pathways, but also what's happening in demographic shifts across the state, but in specific regions as well.
It's such a great point, and I think we've been talking about that for the behavioral health talent assessment that is just getting underway, and really, and I think we've seen that in some of the nursing data. It's a both and what is the geographic distribution of the workforce? What is the workforce distribution by other demographics, race, ethnicity, gender? It doesn't look the same across the state, and it's that sort of gap in regional data that we hope to explore a little bit. And I do think it's that integration of supply and demand and how we pull all of that together with a big red bow.
Right. Pretty complex.
Other thoughts and comments? And I have a brainworm, but.
I wanted to address your first bullet of what groups would find this information helpful. I think our school districts and our CTE consortia would find this very helpful, because when you're developing a program of study in CTE, you need to look at the local needs assessment of in-demand, high-wage, high-skilled jobs. So they're already doing that work, because it's required by our federal grant, Perkins. So that would just be even more information.
Cool. Other thoughts? And I appreciated your nod, Jennifer, to like 2025 planning and how this impacts that, because I also think we've been doing some thinking, and one of the findings in which if we had all day, we would have the essential employability skills folks here to also talk about that great work. But thinking about some of the findings across the consortia, and one of the bullets that Eric had on the slide was around, students leaving and not being prepared. And so I think about essential employability skills. I also think about work-based learning opportunities, and that being just. It's not a shock. I don't think any of us are shocked by that, but it's also like, okay, like what do we do about that? And I think that Eric was hearing that across the consortia. So they're going to be in their October meetings, hearing from Eric around what did we find in manufacturing? What did we find in technology? And are there any kind of cross consortia opportunities? And that, like, people not leaving the education system prepared is one of those findings. Is there something that all three consortia could potentially work on? That's just a broader workforce system.
So good question. Is the data from the focus group will be shared with the governor's office, legislators? What's your goal regarding the data?
That's a great question that I don't have a good answer to, but I could switch my hat
Well,
It's Sarah, I think that. I think that we in particular need to find a forum for that, and I'd ask you, Marin, if you would think that this information would be helpful in any of your capacities. I know I will be asking to share this with my colleagues in the governor's office.
I mean, and I'll just add.
Sure.
The Jensen will be presenting at the Manufacturing Consortium next week and the Technology Consortium at the end of October. And then the full focus group findings report will be published and publicly available. So I would say in that November timeline, we should be thinking about actively sharing the focus group findings more broadly.
Because part of the work of our Racial Justice Council is we're meeting with the governor on October 29th to make recommendations based upon our thoughts of all the POPs, legal concepts, plus everything else that we can deal with. And so I think this data is really important. I mean, it's really enlightening to really use the data to our benefit and advocacy for this work, but also future work. So I would love to have the RGC have the reports.
Yeah, absolutely.
And I'll just add to, in that sense, that even like looking at this bill is like, there's bills and some funding, then it runs out, and to your point of like, you know, making up for inflation, like there's over that. But as long as there's some security, like that funding is gonna stay there, and it's, you know, we have legislators, the governor, everyone like knows that this is something that's in place rather than, you know, a small group of people in different regions talking about it, but just make it broader knowledge to give that support. And this is where I see, you know, it's you know, people who are making decisions on funding and say, no, we're not gonna touch that, or, oh, we did that last time. This session, we're gonna, you know, shift funding onto something else. This is where, even with the Medicaid waiver, we're finding out that it's not a one time and it's done. Like it needs to be consistent investment, so.
Yeah, and I think that's, I want to just name that we've had our research team and Alex and our research team is here, and they've opened again, so these investments take time. And it's not in a year, we're gonna get it, and you know, I think.
No.
Dan, you said it well, of like, I mean, I think the system moves. And sometimes it moves quickly, sometimes it moves, but we have to give this time, and so our research team has been really good at teeing up like potential future impacts, but in the interim, you know, staying the course on the work. Sorry.
You know, from a higher ed standpoint, you know, I mean, one place that this could be used, I was kind of thinking like from a CTE standpoint, when we do outreach, higher ed does outreach, say we have these opportunities, you know, I think you're hearing more, we're trying to go into middle schools, we're going into high schools, we're trying to educate families, often try to think of giving them social capital. So there's that, but this closes another gap that I think we should try to amplify. And I think I might've mentioned this before, you know, who creates programs at universities? It's the faculty. Sometimes administrators give them a nudge or a little support to do that, but the faculty have to be on board. Then what the faculty have to do, they need to sell this to HEC. They need to sell this to the faculty senate. And one of the places we have a really hard time getting information, what's the workforce demand and what does it pay? And if we can put that into the proposals, if we can get that out to the faculty, that's just something that can be available. I think that would make us a little more nimble in terms of responding to market needs.
Yeah, and I think one of the findings Eric had on there was kind of this repository, this kind of information sharing and having that in one place, and also being intentional about making those connections and sharing data.
I mean, I think the other part is employers. I mean, that's a big piece. So, I mean, Rob, so you're thinking that faculty is disconnected from the reality of how the workforce plays day to day in terms of the reality of what people deal with.
Yeah.
So they build curriculum not really based on reality in terms of.
Well, yeah, there are two things. And for that part, I'd go back to one of the things that came out of the focus group in the morning is advisory boards. And I kind of heard of a state level position, that's fine. But really, you need to have it at each program level. Then the faculty are hearing it from the employers in the region. And those employers, they'll send people, they're very willing to do that. I think that begins to close the gap with the people that are developing the programs, the people that really need to decide, because they don't get paid anymore. They're gonna have to work an extra 10 hours a week to launch this program. They're not gonna get paid anymore. And this really can kind of show them, hey, there is a need here. This can be something to help your community. There's that. But then when they go to start a program, they need data. And it's really hard to develop these new programs, especially for the smaller schools. The regional schools have a really hard time getting the necessary data to know, is this a good decision? And then sell it to their board, sell it to their faculty senate, and get it approved at HEC. So, yeah, I think both.
Yes, and what I heard in the focus groups too is the challenge is the short, like, the way I think about it is that education and training programs take 2 to 4 years to develop and implement. And industry is planning on a year basis. So there's a mismatch in supply and demand, but what can a forum like this, like, how do we close that gap? Because I can put myself in both, you know, of the employer and the education shoes and have empathy for both of it. Is like, well, what's the incentive for me to build out this very expensive program without knowing if there are going to be employer needs on the end? But I think that with some of the employment data and some of the longer term, like, supply forecast or demand forecasting, I think we know that we're going to need more nurses and we're going to need more techs and we're going to need more behavioral health occupations. So I feel like we've got some solid ground there, but a lot of work to do still.
I think one of the challenges too on the education side is programs are really expensive to start up and they take a lot of time. And then they're really expensive to maintain. You know, we started a dental therapy education program with Skagit Valley College in Washington State. And it's like every single year we're like, oh my God, where do we find $5 million? Because we can't charge our students enough to make the program self-sustainable, because that would just weed out all the students that we want to have. We can't get tuition down to community college like rates, because then we can't afford to run the program. And, you know, and then where do you find a pot of money that's large enough and recurring enough to then continue to support the program? So there's, you know, I want to make sure we don't lose that. We can get these programs started. I'm sure there's always money for starting programs, but then how do you maintain them over the course of, you know, the sort of lifespan of that demand and make it affordable to the students that you're targeting?
Here. We are about at time, and I want to give us some transition to do our, for those that want to stay to tour the building. It's time to do that, but.
Before you wrap up.
Okay.
I just want to first thank Dave for helping facilitate pulling all of this together, and to Rogue for hosting us today. I want to thank Sarah. I know Becky did a little bit of this, but it's just been such a joy having Sarah on this team, and thank you for sticking around to help with one more conversion meeting before we bid her farewell as she transitions to her role in the governor's office, which apparently she already has. We didn't know that. So join me in thanking Sarah for all of her work. Launching this body of work known as the Healthcare Industry Consortium. I think I have a slide that says, watch for 2025 meeting schedule. We'll be transitioning your leadership to Maggie. So also welcome to Maggie Forey, who hopefully you've had the opportunity to connect with. We're so grateful to have the opportunity to be in the region and to visit all parts of Oregon and really get the opportunity to hear from you all in community. And I was just sharing earlier, I love what I see as a maturity of partnerships and a really sort of collective impact approach to education and employment that's happening here in Southern Oregon. And so it's really, it's a pleasure to be here. We look forward, I would hope at least once a year to hosting one of the quarterly meetings across the state. I think this has been incredibly valuable for consortium members, but also the opportunity for community to engage in our work and showcase everything that's happening here in the region. So just thank you all for participating in today's meeting and really looking forward to the tour. I don't know if you want to tee that up, but just to wrap up my transition, we'll be communicating with you all the 2025 meeting calendar. I think we've made the commitment to having your winter meeting fully remote so that no one is having to worry about traveling to be present for that. So I anticipate your first meeting in 2025 will be fully remote. And then we'll get the rest of the calendar put together with your leadership team. And with that, I'm going to turn it over to Dave to give us some instructions.
Sure. Okay, so I think we'll take like a quick break before we get started, and then my partner in crime, Lisa Parks here, she's the dean here doing the workforce training side of things. We will meet up in the front of the lobby in about 5 minutes or so. And we'll go ahead and give you a tour of this building.